a lot of our multifocal patients or patients that are looking for needing that presbyopic correction are existing contact lens wearers, which we're now starting to fit the Gen Xers, the Gen X generation.
Which is my generation.
Which is my generation, yeah. Which is my generation.
Are we in the same generation?
Absolutely. Which is a little different, actually, than fitting the baby boomers. The baby boomers have past experience with other types of lenses, whereas the Gen X generation grew up and have been wearing soft contact lenses for 20, 25 years. And they have different expectations than the baby boomer generation.
Right, and most of us have already moved those patients into silicone hydrogel or more comfortable ideas.
10 years ago.
Yeah, we've already had that conversation. So now, the good news is, as Dave was saying, that all the modalities, regardless of brand, have their flagship material has a corresponding multifocal lens there. So you don't really have to play the game of, okay, I'm sacrificing in one direction to go to the other. You don't sacrifice anymore. And that makes it a lot easier to make these conversations. Where it gets interesting is, obviously, there are certain multifocals that are definitely better than others. And so sometimes you have to make some adjustments, but the good news is that all the materials have the good oxygen transmissibility. You can have the conversation, and the patient doesn't get quite as skittish as maybe they did 10 years ago about, okay, we're making a change, but it's still going to work out great for you.
Well, there definitely, in terms of multifocals, we know there's a difference, and we're going to get into a little bit more of that as we go. But the other aspect of this thing is, and I think you can pretty well see where this conversation is going with our panel, but that is there have been a number of studies that have shown that approximately 7 out of every 10 patients prefer multifocals over monovision, and that patients prefer multifocals to monovision in practical activities as well as real-world settings. Do you agree or disagree with this statement in your individual practices?
Well, Jack, I think, and I'm going to answer your question in a moment, but this is a good thing. And I do, but this is the important part of this. Ties into that question, which is, I believe, especially as we deal with more and more specialization of the product that we're putting a patient into, we have to not pretend just because this system has become easier for us to fit that we don't have to spend as much time with the patient. And you touch on that perfectly, which is we're doing a specialty fit of a multifocal contact lens, which is a device that is a lot different than what they've worn in the past. We shouldn't shirk away from that specialization just because it's easy to fit the lens. We should sell that specialization or explain to our patients, because we're putting them in specialized lenses, we need to have more specialized care for the patient. We should see them more often, because that way we hit upon all the dry eye issues and stuff. But at the same time, just because a lens, we'll use torics as an example, just because torics became easier to fit 15 years ago doesn't mean that we don't need to see the patient for the rotation and things. Just because multifocals have become, through the different nomograms that we use to fit the patient, just because it's become easier to put a patient in there and make them happy in multifocal, doesn't mean that, oh, we'll see you in a year.
Sure.
And to the point of the question you're asking, no, I feel much more comfortable fitting a patient with a multifocal lens than monovision for that, right? It's a better system for them. Not to say, again, 7 and 10 is true. There is that percentage that may be more comfortable in monovision. But the truth is, they're not the preponderance, they're just the outlier.
So if everybody does feel that way, and I'll just make the assumption that everybody does at this point, but if you feel differently, I'd like you to say so. Is there an evolution in your practices toward greater multifocal use today, or are we just sort of giving lip service to that versus monovision?
I think we've reached a critical mass level. And with any introduction of any new technology, there are the early adapters, and then there are the mid adapters, and then you reach a critical mass where really it's expected. It's expected of you as a practitioner. Patients are expecting it. It doesn't involve large conversations anymore. It's, oh, you're 43, you're having some near problems, let's put you in a multifocal. And that's really the whole conversation that has to happen with the patient, because the patient just gets it. You get it as the doctor. The patient gets it as the wearer of the lens. And once it reaches the critical mass, which is really where we're at right now, it's standard of care. It is considered standard of care within the industry. Not that monovision is completely out. We all understand how to manipulate monovision, but we all understand how to manipulate the multifocal context. And the optics and I'm going to keep going back to optics, but the optics of multifocals aren't such a mystery to us anymore. We just somehow intuitively understand how to manipulate the optics of those to get what each individual patient needs. And I think that's where we're at right now, is it's just so comfortable for us as doctors, because we've reached that critical mass, that it comes across to the patient as we are comfortable, and then the patients will have this greater respect for our practice as well.
Do you find a mirror image? And I graduated from optometry school right at the beginning of soft spherical disposable lenses for astigmatism. But it seemed like when I was coming out that some people were still having a little trouble with that idea. And now you ask those patients, you ask those doctors 15 years later, and nobody says, oh, I still mask astigmatism. Do you feel it's almost the same, a parallel conversation?
It's a parallel conversation for almost any specialty type lens that's out there. Whether you're talking about toric lenses, whether you're talking about scleral lenses. You know, we're starting to reach critical mass with a lot of different type of what we used to consider specialty contact lenses that are now considered mainstream. I don't think there's any doctor out there now that if they see 0.75 diopters a cylinder wouldn't just automatically think toric lens.
Well, a multifocal changes people's lives. Monovision's dead. I mean, I would like the panel talk later. Please bring this up. Why are people fitting monovision? You know, and you take a 50-year-old individual that's starting to have crystalline lens changes, and you take one eye and just blur it out completely and put them in a car at night. This is ridiculous in the 21st century. I mean, and our patients, if they're going to wear monovision, they have to wear driving glasses, because why would you take away vision from somebody at night on purpose and not even give them the option to bring it back? I mean, there's a safety concern out there. There is evidence-based medicine that shows you lose vision at night with monovision more than with the multifocal. So as far as a specialty, we need to treat it as such and understand all these conversations have to happen each and every time to every patient.